Objectives of today's talk are to understand the structured approach to a seriously injured child, to learn how to clinically assess the sequence to identify life-threatening injuries in a child, and to understand structured approach to a child with head injury. Now, we all should always remember that pediatric patients are unique. Literature on trauma care has focused mainly on adults, but all the issue may not be translated from the adults into pediatric population. First and foremost challenge which is unique to pediatric population is vascular access. To obtain the cooperativeness of the child itself is a big hassle. Then when you try to be very aggressive with the kids, they are bound to have psychological trauma associated with whatever physical trauma they have. Their veins are smaller and they have more subcutaneous fat, so to get an excess it's a difficult thing to do. Pediatric trauma patients, they have additional issues of having higher likelihood of hypovolemia. They have lower success rates of IV intravenous cannulation by first responders with consequent hematomas and bruises. And why this is important? Because when we ask our nurses to put in a cannula in a pediatric patient, we don't know what their experience is. And when they try too much, then we lose more time, more fluid, and more time to resuscitate such kids. Also, these kids have more of fractures in the extremity bone. They are more prone for hypothermia, causing peripheral vasoconstriction. So these are additional features which makes cannulation a difficult task. Second aspect is dosing. When we talk about dosing, the traditional weight-based dosing, and if we know the weight, we calculate. But when we cannot measure the weight, then Broslow tape, length-based resuscitation tape, it is very helpful to help and make you understand various parameters involved to take care of child's health. And when you are managing a trauma child, it is very much easier for you to have one hands-on list of all equipments with respective sizes of everything needed in one place. Broslow tape should be a must to be an add-on in your ED cards. Fluid management in trauma patient has only one goal: to provide adequate oxygen delivery. And always remember, in any polytrauma patient, adult or pediatric, you should always have two age appropriate IV cannula in place when you start resuscitating them. Clinical categories, while assessment in trauma patient is divided into three main categories: compensated shock, hypotensive shock, and cardiopulmonary failure. Now, to get to these categories, we need to assess these physiological parameters. That is, we have to assess the heart rate, presence and strength of pulses, blood pressure, respiratory rate, mental status, color and temperature of extremities, and capillary refill time. Urine output is also a very important marker. This has been reinforced by Pediatric Advanced Life Support 2011 and ATLS 2008. Since then, these factors have been reinforced to all the clinicians who are taking care of pediatric trauma and associated trauma patients. When there is a mild hemorrhage and compensated shock with less than 30% blood volume loss is there, child presents with mild tachycardia, weak peripheral pulses, strong central pulses, and mild acidosis. There is mild tachypnea, cool extremities and mottling, capillary refill is more than 2 seconds. In this slide, when we go ahead, we can see that moderate hemorrhage and severe hemorrhage is categorized by the amount of blood volume loss. 30 to 45% blood volume loss is associated with moderate decompensated or hypotensive shock. And more than 45% loss will lead to severe hemorrhagic cardiovascular failure and will lead to cardiovascular failure very easily. Cardiovascular, respiratory, skin, they all are subjectively helpful in assessing. But CNS, if you see that irritability, anxiety is seen in less than 30% volume, agitated, lethargic is in 30 to 45% of blood volume, and obtunded and comatose state is more than 45% blood volume. Along with CNS, urine output moves from mild oliguria to marked oliguria to anuria. Rest all the parameters, they are pretty more subjective, like capillary refill time 2, 3, 5. So you have to actually do the micro circulation assessment. But at the same time, You can also, if you start assessing urine output and you start assessing their sensorium, this will be a very good and a very quick guide for you to decide the type of blood loss they are having, so that if at all you are considering that only superficial injuries are there and there is only less than 30% blood volume loss, but actually child has concealed blood loss in intra-abdominal or in thighs, then you will be able to understand by checking out the sensorium, looking at the urine output and touching and checking for capillary refill. ATLS also practices the same guidelines on transfusions. So we start with 20 ml per kg of crystolite. We repeat it for 1 to 2 times. If vascular status is normal, we further evaluate and transfer to watts. If vascular status is abnormal, after 2 boluses, we give 10 ml of PRBCs. After that, if it is still abnormal, we take this patient for exploratory laparotomy or associated injury correction under surgery, and we operate. If after bolus of blood, say, physiological stability is achieved, we keep the child for observation, and as kid deteriorates, we operate. Otherwise, we observe and anticipate and transfer to intensive care unit as needed. Special care need to be taken in toddlers and infants and small children who are less than 20 kg. Always remember that in smaller children less than 20 kg, the most efficient pump is 10 cc syringe, and it is not the usual pump which we use in our drug administrations. Because infusion pump, they actually push in at a pace which is sometimes harmful. When we transfuse blood too fast, it can lead to complications like pulmonary edema or hyperkalemia. We are going to discuss more on blood transfusion in upcoming slides. Along with the transfusion, we should always remember that glucose should be kept out of resuscitation fluid so that we can prevent hyperglycemia. This doesn't mean we need not to monitor glucose. We have to monitor glucose because normoglycemia is what we should target. Hyperglycemia is associated with increased risk of infection and increased length of stay, and hypoglycemia causes increased chances of mortality. Resuscitation fluid, crystalloid versus colloid, is a common question in mind of every emergency physician, adult or pediatric. There is lack of strong evidence which justify the use of more expensive non-blood product colloids such as albumin or starch as compared to crystalloid solution. In fact, research has shown in traumatic brain injury, use of albumin has been associated with poor outcome. So it is not recommended to use for plasma for expansion in resuscitation. For maintenance fluid, rule of 4 to 1 should be utilized. Holiday Seeger method of up to 10 kg with 4 cc per kg per hour. From 10 to 20 kg, add plus 2 cc. So 4 into 10 is 40 plus 2 cc per kg per hour up to 20, up to 10 kg for next 10 kgs, and above 20, 60 plus 1 cc per kg per hour for every kg above 20. Maintenance fluid formula is very important in calculation because this maintenance fluid, if calculated wrong, then you are going to jeopardize entire circulation which need to be maintained after surgical procedure is done or you are planning for surgical procedure. The use of blood transfusion should be strongly considered as the primary resuscitative fluid until hemorrhage can be controlled in patient non-responsive to crystalloid. And ATLS also recommend the transfusion of a patient if still has a sign of shock after 2 boluses of 20 cc per kg of a crystalloid, then as we have discussed in the previous slides, then blood transfusion is indicated. What is right blood for trauma patient? It should be recently collected, freshly irradiated, and should be CMV safe. And there should be ideally in cases of emergency, you can transfuse uncross matched O negative blood, and it is very important to have this practice, to have at least 2 bags of uncrossed matched O negative blood in your unit if you are managing pediatric trauma very often. Very common problem which is noticed and has been observed and is a killer in case of massive blood loss, either to trauma or through comorbidities, is massive transfusion. Now, what is massive transfusion? It is transfusion of blood component which is equaling one or more blood volume within a 24-hour time frame or half of blood volume in 12 hours. Now here we see that for an infant it is 80 ml per kg. Keeping a target weight of 5 kgs, it is only 400 ml. One aliquot, which is the blood volume which we receive, is 300 ml approximately from any blood bank. So if in a 5 kg old child, 5 kg weighing child, we transfuse more than 300 ml, then this kid can go into massive blood transfusion related complication. Why I'm stressing upon this is recently we have came across such a child and we were struggling with massive blood transfusion because child had lost a lot of blood. We were not able to save this kid, but again in clinical practice we learn from our patients, and this is a very important slide in this presentation because massive blood transfusion is a very unique way of handling massive blood losses, and if done correctly you may save a life, and if you do it wrong then there is no way you're going back and doing good to the patient. Because when you transfuse a lot of blood, coagulopathy of trauma starts happening. There is hypothermia, there is hemodilution and acidosis, which further lead to worsening of coagulopathy. Now, hypothermia is a result of shock because of blood loss, exposure because of child is young, small, a lot of heat loss is happening, and large volume resuscitation using room temperature, which decreases platelet adhesion and activation. This transfusion with crystalloid previously given causes hemodilution, or PRBC unit without sufficient co-infusion of FFP and platelet will further dilute clotting factors, and because the blood stored from the blood bank will be bit colder and will not be adequately warmed, and in situation with emergency we try to rush and put in blood, this extra load of temperature is going to add more and will worsen the problem of hypothermia. Acidosis results from the shock, which further inhibits the proper clotting factor function, and it leads to worsening of coagulopathy. Massive blood transfusion protocol have been adopted worldwide to minimize the effects of lethal triad. So when you have reached approximately 1 blood volume loss, that is the time when you have actually transfused more than 30 ml per kg of PRBC, you need to put 20 ml per kg of FFP along with it. And when you have transfused, you have given 2 blood volume loss. After 2 blood volume loss, you need to add 20 ml per kg platelet and 4 ml per kg of cryoprecipitate if you are able to get cryo. Recombinant factor A7A is only given after physician discretion, and this is usually considered if the ongoing bleeding persists or the loss of 3 blood volume has happened. That is the reason the first slide where we were telling about the volume of blood, which actually marks what is the circulating volume, is age wise. For this reason only, on virtual PICU group, I have shared an article which you should go over. Before routine use of recombinant factor 7A, more studies are need to be done so that we routinely recommend it. Presently, potential benefit cannot be debated. Now, what is the outcome and what are the complications associated with under resuscitation in trauma patient or over resuscitation? Under resuscitation will lead to multiple organ dysfunction, with kidney and liver being the most susceptible organ because kidney receives 26% of our circulating blood volume every minute. Over circulation will lead to extra fluid in periphery and lead to peripheral edema and life-threatening pulmonary edema, especially in children who have pre-existing cardiac or renal diseases. What will be the complications? Procedure related will be extravasation from the line site, infection, pneumothorax while putting central line, perforation of heart has also been seen while you are going aggressive. Nitrogenic complications, hypothermia, air embolism, transfusion reaction, subcutaneous infiltration of IV fluid, hyperkalemia, hypocalcemia, and hypothermia if blood products are not sufficiently warm during transfusion, and it causes more problem. Other aspect with trauma patient is tetanus. Now, tetanus is a serious infection that can lead to death, although it is not contagious and it is completely preventable by series of vaccination. It presents in the form of high-grade fever, high blood pressure, muscular spasms, locked jaws, sweating, and difficulty in swallowing. Guideline to treat with tetanus prophylaxis is very simple. If you are dealing with a clean and a minor wound, and patient has completed primary tetanus diphtheria series vaccine, and you are aware that the patient was vaccinated in last 10 years, then no new vaccine is needed today. If status is unknown, then you give vaccine, DPT. If either way, if you are not aware about the 10-year schedule, or you know that within last 10 years this patient has not received, you give appropriate dose and you administer vaccine. Apart from clean minor wounds contaminated with dirt, feces, saliva, soil, puncture wound, avulsions, wound resulting from flying or crushing object, animal bites, burns, or frostbite, this patient should be undergoing primary tetanus diphtheria series vaccination is complete or not. We should be aware of it. If yes, was it done in last 5 years? If yes, then no more vaccine needed. If no, we have to administer vaccine. If the patient or attendant mentioned that no, this was not given, the primary series is itself not completed, then this is the candidate for tetanus immunoglobulin along with vaccination. A guide to tetanus prophylaxis in wound management is 3 doses of vaccine immunization less than 5-year time for the last dose. 3 doses, more than 3 doses, 5 to 10 year. Yes, we in the clean wound, it's only vaccine which need to be given. If 10 years have elapsed and more than 3 doses has been given, then we have to consider only vaccination if there is clean minor wound, and all other wounds, if dose of primary vaccination is uncertain and there is a clean minor wound, then we are going to give only vaccine. Apart from clean minor wound, we are going to consider tetanus immunoglobulin. Dose of tetanus immunoglobulin is 250 international unit. It should be given by IM injection. If more than 24 hours have elapsed after injury and trauma, 500 IU is the dose for the children. Always remember, tetanus immunoglobulin should be given slowly and should be given with a 23 gauge needle because it is highly viscous. Individual with a humoral immune deficiency, including HIV infected persons who have immunodeficiency, should be given tetanus immunoglobulin even if they have received tetanus prone injury, regardless of the time since their last dose of tetanus containing vaccines. What is the role of antibiotics and how are they useful? So antibiotics, prophylactic antibiotics usage, although it is very frequent, but it is very weakly supported by research. They do not overcome poor wound management. So our wound management should be robust. Otherwise, we are just going to add more fuel to the present war against drug-resistant infections. Open fractures, they are categorized as grade 1 with wound less than 1 centimeter long and clean, grade 2 with wound more than 1 centimeter without extensive soft tissue damage, and grade 3 with open segmental fractures, open fracture with extensive soft tissue damage or traumatic amputations. Bacterial contamination can lead to cellulitis, osteomyelitis, and bony non-union. It should be best managed by debridement of devitalized tissue with concomitant antibiotic therapy. Infection rate of grade 3 open fracture is around 24%. Cefazolin or category 2 cephalosporin drug are good enough for grade 1. Cefazolin and gentamicin for grade 2 and 3 until wound is closed. Now, grade 3 is that when prophylactic antibiotic should be given as soon as possible after injury for coverage of gram-positive organisms. We have to add gram-negative coverage as well. And if we are thinking about fecal or clostridial contamination, then high-dose penicillin. When should we discontinue antibiotics is a very important question which every clinician should ask himself or herself. So grade 1 and grade 2 fractures, 24 hours after wound closure, we have to discontinue. Grade 3, continued for only 72 hours after time of injury or not more than 24 hours after soft tissue coverage of wound is achieved, whichever comes first. Chest tube placement is the general procedure in ICUs. There is an incidence 1 to 2% of empyema. So a single dose of prophylactic antibody at the time of placement reduces the risk of empyema. There is no evidence which supports routine prophylactic usage of antibiotics in skull-based fractures if it is happening without meningitis. And this is irrespective of CSF leak. Whenever there is a vascular injury, single dose of first generation cephalosporin for 24 hours if synthetic graft is used. With penetrating abdominal trauma, single preoperative dose of prophylactic antibody with cefazolin or ampicillin sulbactam is sufficient. It should be given as soon as possible. If there is no peritonitis, we can discontinue antibiotics within 24 hours. With this background, let us now go to cases. So we have a 12-month-old female child who was brought by a relative. There is history of pain and swelling in right upper arm. There is history of fall from bed 2 days back. Swelling is present over right forearm. It is erythematous and bruising is present. Child is not moving the limb. How will you approach this child? X-ray reveal this with the fracture of humerus. Yes, we are going to go for an X-ray. We are going to go for analgesics, orthoopenian and splinting, follow-up after 2 weeks. Is it so? Let's see. Whenever we deal such children in pediatric emergencies, we should have provisional diagnosis. And we should always ask how to proceed. Second question is, what are the risk factors which make these children more prone for abuse or such problems? Because I'm sure you must be thinking about child abuse in this time. Now, the problem of child abuse is a global problem. With over half of the children aged 2 to 17 years have experienced emotional, physical or sexual violence in past year. It has serious impact on victims' physical and mental health, well-being and development throughout their lives, and by extension on society in general. Risk factors are at individual level, familial level, society level, and community level. So, a poorly educated, low income, disabled family member, child will be more prone. Lack of emotional bonding because of gender, broken families, violence against intimate partners, child will be more prone. Dangerous neighborhood, drug abuse, inadequate child protection services, child will be more harmed. Gender inequality overall, legal and social norms that encourage violence, child will be more harmed. So child is the epicenter for any kind of societal insult or any kind of instability in society. What are the role of emergency physician? Role of emergency physician is to have a differential diagnosis of any injury or any physical or psychological complaint that does not have an obvious etiology and keep this differential of child abuse in your thoughts. Protect this child, report this abuse, and initiate adequate social service or police authority in your area, howsoever you are ready to deal with such kind of issues with the children you are handling. When should we suspect this non-accidental trauma? If the history, one of the inflicted injury doesn't match, if history over or underestimate the injury, if there is absence of history or there is a magical injury, if there is inconsistency or change in history, if there is repeated history of injury or hospitalization, if there is delay in seeking medical care, if there is a medical history of prematurity, failure to thrive or failure to receive adequate medical care such as immunization, if there is high risk history, example fall from downstairs, dropped baby, this could the injury have been avoided by a better care and supervision? If that thought also comes to your mind, think about child abuse and negligence on the side of parent. As physical abuse is the most visible form of abuse, what are the telltale signs of physical abuse? These are bruises, bites, burns, fractures, abusive head trauma, retinal hemorrhages. How common are these fractures? How specific are these fractures? Do we need to do skeletal survey for every victim who comes to us with skeletal trauma? How and what all investigations should be useful in this child? So fractures, they are the most common among abusive injuries where medical help is sought. And they come second to the dermatological findings. Age and distribution of fracture distinguishes abuse from accidental. Abusive fractures are uncommon over 36 months of age, when child starts vocalizing. You should always remember that you should rule out nutritional and metabolic bone disorders before coming to conclusion. The posterior rib fractures has highest specificity for child abuse, followed by metaphyseal corner fractures. Now, multiple fractures of different ages with associated finding in history and physical examination may attribute to child abuse. Femoral fractures and fracture of humerus in a non-ambulatory infant have a very high specificity for child abuse. Fracture of scapula, sternum, and spinous process of vertebra should also alert a physician about possibility of child abuse. This is the guideline published in Pediatrics, under which the skeletal survey, when to do, in whom to do, which is mentioned. So for a child who is less than 24 months with bruising, and if any of the following feature are present, that is, abuse is confessed by the parent, bruising is occurring after domestic violence, additional injury on physical exam like burns, whip marks, pattern bruising is there, more than 4 bruises not limited to bony prominences, ear, neck, torso, buttocks, genital region, hands and feet have bruises, and there is no history of trauma, you need to go for a skeletal survey. If less than 12 months and you see bruises on cheeks, eye area or ear and neck, upper arm or legs not on the bony prominences, torso, buttocks, genital region, or more than 1 bruise not limited to bony prominences, go for skeletal survey. When child is less than 9 months, more than 1 bruise in any location, go for skeletal survey. Less than 6 months with bruising at bony prominences, except if a single bruise and patient present with history of fall, you can avoid, otherwise go for skeletal survey. Now skeletal survey, you should always do a survey of appendicular skeleton, that is humerus, forearms, hands, femurs, lower legs, feet. Do not forget the axial skeleton, that is mid part, thorax, ribs, abdomen, lumbosacral spine, skull and cervical spine. Technique should be high resolution, high contrast. To rule out metabolic and nutritional disturbances and other associated injury to other organ system, evaluate by doing CBC, transaminases, lipase, amylase for pancreas, PT, APTT, PT, fecal occult blast for GI, liver injuries, urine analysis for urogenital tract injury, urine toxicology for associated trauma and toxicology, dilated indirect ophthalmoscopy to look at for retinal hemorrhages, and head CT for if there is sensorium which is not right to detect subarachnoid, subdural or intraparenchymal injury. Another aspect in these cases is documentation and what all information we should not miss to mention. There should be detailed handwritten notes, simple diagrams and body chart for inflicted injuries. Photographic evidence are most important in medical legal aspect. Each injury should be photographed separately. Ensure that both the injury and the body part are captured in the frame. Size of all bite marks should be measured and documented. All bite marks should be photographed. A swab should be collected from acute bites for forensic analysis. Now, how should we respond and manage these? Our response should be child-centered and child-friendly. It should be family supportive. And our management should be symptomatic and documentation of the case should be robust. Whenever we talk about child abuse, I would like to ask how many of us categorize burns due to child abuse and what is the characteristic feature of such burns? This is the answer. 1 to 35% are intentional. Immersion burns are usually symmetrical with a clear line of demarcation. Splash burns are absent and the burns are of uniform depth. Burn in glove and stocking area. And symmetrical perineal burns are characteristic of abuse. Now going to case 2. An 8-year-old is brought by ambulance with multiple injury following a collision with a motor vehicle while cycling without a helmet. Physical examination is 15 by 15 GCS, palpable fracture on the back of her head in left occipital area with an overlying 5 mm laceration. CT was done. It was suggestive of a depressed fracture, which was about 10 mm in depth and no obvious underlying brain injury. What should be our ideal best step in management of this patient? Questions which should come to your mind are: is surgical interventions recommended? And what are the usual bones which are involved in depressed skull fractures? Remember that surgery is usually required if depression is 5 mm or more. And depressed skull fractures are most common in frontal and parietal bones, which are followed by temporal and occipital bones. You have to always reassess these patients and manage other life less threatening injuries in a timely manner once you have anticipated the need of surgical intervention. How do we assess any patient or trauma in emergency? And what is the purpose of such assessment? We assess trauma in emergency under this rule of A, B, C, D, E. That is airway maintenance with restriction of cervical spine motion, breathing and ventilation support, circulation with hemorrhage control, disability with prevention of secondary insult, exposure with temperature control. Our purpose is identify life-threatening emergencies and save the life. You should always treat first what kills first. What are the associated injury in motor vehicle accident cases which can be detrimental and we should take due precaution? And how do we maintain spine stability? Always assume that patient who had an injury has a cervical spine injury. Restrict cervical spine motion until spine is cleared. Manually stabilize initially, followed by application of cervical collar. On the group, I will share you the video of how to do that. In this is the step 1. You hold two responders. One is holding the neck and keeping the head in midline. The other one has applied the collar now. Head in midline with manual inline stabilization is the first step. Cervical collar second, side rolls and head strip third, and soft collars and sandbag alterns are fourth step in maintaining the spine stabilization. Is CT scan needed in all head injury cases or is there a rule to follow? Yes. PCAN rule, Pediatric Emergency Care Applied Research Network, suggests that CT head in a child who is 2-year-old and has multiple findings of history of loss of consciousness, severe form of injury, history of vomiting or severe headache, go for CT. Child's clinical decision rule, consider loss of consciousness of more than 5 minutes and a fall of height from more than 3 meters as high risk criteria, go for CT. Catch clinical criteria proposes that a dangerous mechanism of injury, such as motor vehicle crash, fall from more than 3 feet, 5 stairs, or fall from bicycle with no helmet, is a medium risk for injury for CT scan. That means just don't go for CT in every child who has a fall. Evaluate for C, consciousness, vomitings, headache, mechanism of injury. Then plan CT. As soon as a patient walks in with injury, go for CT? No. What is the way to assess airway in these children once we have stabilized their spine? Let us talk in a form of a case. A 4-year-old boy runs into street chasing a ball and is struck by a car. Emergency medical services have arrived on the scene and have found that the patient is unconscious with prominent lower leg deformity. Patient now arrives in trauma bay and emergency medical services report that witness on the scene said that car has struck the patient and who has thrown into the air. What is the most expected injury pattern and understanding the kinematics of trauma to get to that pattern is very important. Second is Waddell triad. Let us see. So this is the usual pattern when a motor vehicle in accident affects a child. In such cases, you see there are two patterns, technically speaking. First pattern is when child is hit on the thorax and is taken over and under. So children who are stuck by a car with an up and over mechanism tend to present with a predictable injury pattern. That is lower extremity, thoracic injury, and a headache and a head injury, which characterize itself as a Weddell triad. Now, generally what happens is when a vehicle strikes a child, injury pattern differs as per the size of the kid. Larger vehicles like trucks or SUVs have a high bumper and they tend to strike children and drag them underneath the vehicle. Whereas a car often has a lower, often hits the lower extremities of a child because the bumper is low and the child is usually thrown up and over the vehicle. Unlike adults, when a child is struck by a car, they turn towards the oncoming vehicle. As an adult, try to turn away from the upcoming vehicle. Thus, these type of mechanism lead to distinct injury pattern in children, which lead to certain suggestive injuries and complicated outcome. How do we assess? Let us focus on the airway part. Our assessment should be immediate. That is primary survey to find immediate life-threatening assets. Once we are doing primary survey, we do resuscitation side by side. Second survey is focus survey. After we have finished our primary survey, we go to secondary survey. At this moment also, we will be treating the emergency aspect and via resuscitation is continued. Followed by this, we do a detailed review and we reassess the system which is majorly involved. We stabilize and we plan a definitive care. In the primary survey, we look for chest movements, for airway. We listen for breath sounds and we feel for exhaled air. We position the airway, clear the airway, put adjuncts such as oropharyngeal airway, intubate if needed, and surgically intervene if neck and face is injured. We will be having surgical interventions, hands-on workshop on trauma in June. These are the adjuncts which are useful, and in managing a trauma patient, this is the oropharyngeal airway. We decide the size of oropharyngeal from angle of lip to ramus of mandible. This is a LMA, laryngopharyngeal mask, mask airway, laryngeal mask. So it sits on the pharynx. It is a very good adjunct to give ventilation if laryngeal, if intubation is not possible, and if larynx is not compromised. Always remember that head tilt and chin lift is contraindicated in trauma. To manage or to maintain an airway, you always do a jaw thrust maneuver. What and how this airway maintenance is important? This maintenance of patent airway is needed to have inline mobilization of airway so that the tip of shoulder is approximately in line. There should not be flexion. There should not be hyperextension. When we use collars, we should choose a hard collar. To block, we should be using sideways. We should be using head blocks and tape or sandbags so that head stays in midline. When we check for breathing, we have to assess efforts for breathing, efficacy for breathing, and efficacy of respiratory inadequacy. For resuscitation in hospital, we should be having ambu bags, right sides of mask, reservoir, and high flow oxygen devices. Ventilatory support is needed as and when necessary should be utilized. What are the indications for intubation in such children? Whenever there is an impending airway compromise, inadequate support from bag and mask, prolonged ventilation is needed, or controlled ventilation is needed to make this child better. How do we assess circulation and how do we differentiate the various causes of shock in trauma patient and how do we treat it? Now, assessment is dependent on physiological parameters. So there are cardiovascular signs such as which have an effect and tell us about circulatory inadequacy. Before we proceed on managing these, if we have exsanguinating hemorrhage, we need to control it immediately. For circulation, we will be monitoring BP, which is the last to drop in a pediatric patient. Always remember. To assess our circulation, we will be checking the heart rate, which will be high in case of trauma, like in chart we have mentioned. Skin color will be cool. Capillary refill more than 2, more than 3, more than 5, mild, moderate, severe. Keep remembering. And level of consciousness, as we have mentioned, agitated, lethargic, comatose. Is a marker for circulation. Causes of shock, hemorrhage. Blood loss, yes. There are a lot of non-hemorrhagic causes of shock in trauma patient as well, such as tension pneumothorax, cardiac tamponade, cardiogenic shock, neurogenic shock, septic shock secondary to infection associated with injury. Treatment of shock, stop the bleed, direct pressure on extenuating hemorrhage, splint the wound so that more bleeding is prevented. Go for definitive operation so that after stabilization you can do the definitive care. What comes in managing these children? Crystalloid or colloid 10 ml per kg followed by 10 ml per kg. Reassess the response. Again, not responded and blood is not arranged. 10 ml per kg, 10 ml per kg, 20 ml per kg, 20 ml per kg, 2 bolus is given. Assess response. No stabilization, blood. Assess response after giving blood. No stabilization, emergency surgery. Do not wait, anticipate and plan accordingly because time is essence in saving life. How can we quickly assess for disability? Pupils, yes, they are a very good guide for intracranial stability. AVPU scale is very useful in trauma patient. That is, child is alert. If he is responding to voice, then V. Response to pain with GCS 8 or less is P. And if child is completely unresponsive, U. Pupils, yes. Blown out pupil on one side with normal reactive pupil on other, you are dealing with intracranial trauma. Traumatic brain injury leading to intracranial pressure increment with blood as EDH, SDH or subarachnoid hemorrhage. When we expose this child, always remember that heat loss will be there and also embarrassment to the kid will be there. So be compassionate towards these aspects, but don't forget to expose and evaluate completely for temperature and rashes. Now, what all life-threatening complications are associated in such cases? Airway obstruction, tension pneumothorax, massive hemothorax, open pneumothorax, shock, cardiac tamponade, and decompensating head injury. How do we clinically differentiate between a pneumothorax and a hemothorax? And how do we manage? Always remember that in pneumothorax and in hemothorax, breath sounds will be decreased. Percussion is the differentiating factor. Tension pneumothorax will have hyperresonant percussion note and hemothorax will be dull. Trachea will be deviated away in tension pneumothorax and it will be in midline in hemothorax. Neck veins will be distended in pneumothorax. They will be collapsed in hemothorax. Chest movement will be immobile in pneumothorax. There will be certain mobility in hemothorax. Pneumothorax, we put in surgical definitive intracranial ICD. Before that, we do a needle decompression in second intercostal space, and fifth intercostal space in mid-axial line is the definitive site for ICD. This picture represents open pneumothorax management. Whenever we do tube thoracostomy, it is mandatory to be done after needle or finger decompression of the chest. Now, when we have an open pneumothorax, it generally happens as a result of large injury to chest wall. Air passes preferentially through the chest wall defect with lack or with the more defect after, with more chest air movement during inspiration, and effective ventilation is impaired, which leads to hypoxia and hypercarbia. Signs for open pneumothorax are pain, difficulty breathing, tachypnea, decreased breath sound on affected side, and noisy breathing. What we do in this is we close the wound with a sterile dressing on 3 sides. When child inspire, the open side will be sucked in. And when they expire, this work as a valve, and it get it acts as an exhalation valve with flutter valve effect. So during exhalation, this open end is actually helping the air to escape. Until you put a definitive management in place, this saves life of a person. What about primary survey? So after we have resuscitated this child, we go along with resuscitation into history of mechanism of injury to understand what all can happen, understand the status at site of accident, how the injury has evolved. We get a clue from this. We have to check for our responses after intervention and also last meals. Check glucose so that you maintain normoglycemia. Put a gastric tube for decompression of gastric contents. Put a urinary catheter if you don't see blood at meatus, so that you have a good guide of how much urine a person is passing, as we know that anuria is a marker of severe hemorrhage. After we have completed primary survey, we go for secondary survey. In secondary survey, if at all we see that there is deterioration, we abandon it and we repeat the primary survey. Probably we have missed something. In secondary survey, we go from head to toe and front to back. We assess clinically and we assess in detail of all aspects, and we go into focused examination to pinpoint the area involved for intervention. Let us talk something about primary and secondary head injuries now. Now, primary head injuries, only prevention can minimize them. But secondary head injuries, good emergency and critical care can minimize it. What all are primary head injuries? Cerebral lacerations, cerebral contusions, dural sac injuries, diffuse axonal injuries, intracranial hemorrhages. These all are primary head injuries. What are secondary head injuries? Hypoxia, ischemia, secondary to bleed, inadequate efforts, hypotension, airway obstruction, raised intracranial pressure secondary to metabolic abnormalities or infection. How do we triage them? What is Montefiore doctrine? What is CPP? What is ICP? How are they related? When should we consider neurosurgical referral in ED? These are important questions in a child with head trauma, which is one of the most common trauma which all pediatricians and pediatric ER and ICU fellows come across. Now, triaging is very clear. Major head injury with GCS less than 8 is red. Moderate head injury, GCS 9 by 12, penetrating skull injury or depressed skull fracture, open skull fracture, moderate, yellow. Mild head injury, high risk with GCS 13 by 14, GCS 15 with radiological abnormalities, red. Mild with low risk with no radiological signs in GCS 15, green. What is ICP? ICP stands for intracranial pressure. This is the pressure of brain, CSF, and brain blood supply within the intracranial space. Since the skull is basically a closed system, an increase in volume will produce an increase in pressure. How do we manage this raised ICP? Head elevation and head in midline. We can initially do hyperventilation with target ETCO2 of 30 to 35, not below, not above. Studies have shown that hypertonic saline is equally good as 20% mannitol, but it has a better and sustained response as compared to mannitol. So yes, it is better, but as for sustenance of effect, it has a side effect of hypernatremia associated complications. So always keep a track on sodium levels in the body. When we are dealing with a patient with raised ICP, control fever, maintain seizures, avoid seizures, prevent hypoxemia. There should be controlled diuresis, and mannitol is an osmotic diuretic agent. If your ICP has if you have expertise, monitor ICP with a CPP targeted therapy. Now, the concept of ICP is defined by Monro-Kelly doctrine, as per which we understand that brain and skull with parenchyma CSF blood are enclosed in a closed cavity, hard skull. If one component increases, it is going to exert more pressure, and whenever the pressure is there, there will be herniation. This herniation is going to affect pupils. This herniation is going to affect CPP. Now, cerebral perfusion pressure is associated as an auto-regulation mode. Autoregulation of cerebral arterioles with cerebral blood flow remaining constant so that cerebral perfusion pressure of 50 to 100 is maintained. And it has been shown that raised ICP is responsible for 50% of deaths related to trauma. The resultant drop in cerebral perfusion secondary to intracranial hypertension ultimately leads to this problem. CPP is equal to mean arterial pressure minus ICP. How do we manage traumatic brain injury? An indication of intubation. So we manage traumatic brain injury by minimizing and preventing primary injuries, preventing secondary damages, and airway, breathing, circulation, and disability approach. If after head injury, airway is not patent or is not secure, or there is inadequate breathing, or GCS is less than 8, we have to intubate and secure the airway, maintain breathing so that circulation is effective. For head injury, to manage circulation, remember vascular access is most important. Two peripheral large bore age appropriate cannulas are needed. If perforation is not maintained, central lines are inserted and manage shock. In secondary survey, head examination is important. Check for injuries, check for CSF leak, check for mini neurological examination by doing consciousness level evaluation by coma scale, pupillary response to check how and what is the level of injury, check for fundus for retinal hemorrhages, look for tone, reflexes, and power to understand how spine is affected, check for sensations so that you can understand spine injury, Brown sequoia, or cauda equina associated with trauma. When should you go for a neurosurgical referral? Whenever there is deterioration in consciousness level, when there are focal neurological signs, when evidence of depressed fracture is there, when evidence of penetrating injury is there, when evidence of base or skull fracture is there, when coma scale is less than 12. When trauma to head is there and CT scan reveals this biconvex expanding injury, it's a EDH. Then with focal neurological signs, GCS less than 13, skull fracture and GCS less than 15 with raised ICP, this is the time when you go for ICP monitoring if time permits and your ICU is equipped to handle raised ICP. I've shared a video today on the group where we have discussed on skull bolt intraparenchymal insertion of ICP monitor. This is intraventricular monitor. It has associated complications of hemorrhage and ventriculitis. It has certain benefits, certain demerits as well associated. The look out of a normal ICP is 7 and it should never be beyond 20. The raised ICP waveform has 3 waveforms, P1, P2, P3. Whenever we see that P2 waveform is equivalent to P1, that means there is raised ICP features, and this is the time when we go targeted intervention and associated complication can be prevented. Now, normal ICP is less than 6 mm in infant and 5 to 10 mm in children. Normal range is 3 to 15 mm and anything above 10 is raised. CPP should never be below 40. This is our target. It should ideally be above 60 in children, children from 50 to 60, up to 3 years between 40 to 50 and above 60 in adolescent. Again, our entire expertise on monitoring ICP should only be if we have expertise available in ICU. Then we can go for CPP targeted therapy. In case you don't have invasive ICP monitoring, you can have check on pupils. Frequent assessment of pupil give you a good guide of ICP, and this also helps you understand that whether your interventions are working or not. If you have a small EDH and your neurosurgical surgeon is not going to operate right away and they want to observe this patient, it is pupils which gives you window to tell whether patient is declining or not. So make sure for first 4 hours you do pupillary assessment every 15 minutes, after 4 hours every hourly, and after 8 hours every second hourly for up to 24 hours, so that you have a fair idea of how this cerebral insult is progressing. To take home points from all these slides were: maintain airway and breathing. It is of utmost importance in pediatric trauma. Anticipate difficult airway during intubations. Protect cervical spine during airway maintenance. Identify life-threatening thoracic trauma and treat immediately. Examine the children in structured way. Focus on A, B, C, D, E. Consider any child to have spinal injury until it is cleared clinically. Primary survey is to look for life-threatening conditions. Once you have identified them, resuscitate immediately. And if you find problems, continue resuscitation evaluation before you proceed for further examination. Do not investigate patients at your center if you are anticipating a transfer, because you are going to miss on the time window which is in your hand if you have anticipated complications. And if you have initiated transport, just take the samples, but don't send them for investigation. Pull them up with the patient. In case you have any questions, we are ready to take them. I'm going to close the screen share and we are going to take it.